Hi everyone, my name's Ellie, and today I'll be presenting the Ped Surg R1 revision lecture. I put my email just at the bottom of the screen there, so if you've got any questions at all after watching this lecture, please feel free to email me. Today we'll be going through the three Ped Surg R1 conditions, which are appendicitis, pyloric stenosis, and intussusception. I'll just be going over a quick overview of the pathophys of each condition, as well as the clinical presentation, investigations, and management. Just a disclaimer as well before we get started. I've adapted these slides from the 2024 MUPPITS Ped Surg revision lecture, as well as adding some information from the RCH guidelines for each of these conditions, which I would highly recommend for your revision for exams, along with from the MUPPITS summary sheets, which I would also highly recommend, and my own personal notes. So to start off with Ped Surg, we can find quite a few clinical clues from the age of presentation. So for presentations sort of between birth and 2 weeks, we'd be mainly thinking about congenital conditions. So some examples of these are atresia, malrotation of volvulus, Hirschsprung's, or necrotizing enterocolitis. Between 2 weeks and 2 months is sort of the characteristic age for pyloric stenosis. 2 months to 2 years is suggestive of intussusception, and then sort of as we move further towards adolescence, we'd be thinking more things like appendicitis, maybe testicular torsion, potentially even late onset Hirschsprung's. It's important to think, well, these are sort of the Ped Surg conditions for each of these ages. Presentations for these would sort of often be things like abdominal distension or vomiting. So it's obviously also very important to consider non-surgical causes for this. Say for vomiting at any age, you'd be wanting to rule out raised ICP. You could also be considering infection, DKA, gore or gourd, things like that. Yeah. We've also got a table here of sort of some tips to distinguish proximal versus distal pathology. So proximal pathology is any conditions that involve anywhere between the mouth and small intestine. So these can be things like esophageal atresia, pyloric stenosis, malrotation of volvulus, or intussusception. It'll often present with vomiting, bilious vomiting if it's below the ampulla. An important thing to consider with bilious vomiting is that this is always a red flag, always warrants urgent Ped Surg referral, and it should really will be bowel obstruction until proven otherwise. Distal pathology involves any condition that's anywhere between the cecum and anus, so things like appendicitis, an incarcerated hernia, Hirschsprung's disease, and will more often present with abdominal distension, but as you may have realized from that list of conditions there, they can also still present with vomiting. We've got two examples of abdominal x-rays here, which are just another thing to help us distinguish between proximal and distal pathology. So proximal pathology on an abdominal x-ray will have most above L4, which is the level of the umbilicus, and fewer bowel loops as compared to distal pathology, which will extend below L4 and have several bowel loops. We've got a quick overview here of just some things to consider in a pediatric surgical workup. This is probably more relevant for your apexes rather than written exams, but just provides a good framework for things to consider, along with your more definitive management that's specific for each condition. So you've got your two talking things, two oral things, two IV things, and two medical things. So you're making sure you're saying you'd refer to Ped Surg and explain to the parents, which is an important step in any pediatric condition. You make the child nil by mouth and insert an NG tube if needed. Ensure you've cannulated and gotten baseline bloods. There's IV rehydration, and prescribe an analgesia and antiemetic as well. So starting off with appendicitis, which is our first R1 that we'll be going through today. Appendicitis is an acute inflammation of the appendix. It can either be classified as simple or complex. So simple means it's just acute inflammation that's confined to the appendix. Complex means there might be features like perforation, intraperitoneal pus, or an intraoperative mass. It's often caused by obstruction of the appendiceal lumen. Um, this causes stasis of the mucosal secretions within the appendix, which can then allow for bacterial multiplication and then local inflammation. And then this infection can then spread transmurally, which causes the clinical symptoms of appendicitis. It's most common in children aged 10 to 19, and this is typically due to lymphoid tissue hyperplasia, which is physiological during childhood when the lymphoid tissue is maturing. It's uncommon for children under 5 years to present with appendicitis, and if they do, it's usually a late presentation and may present abnormally. On history, there's a classic migrating abdominal pain. So it starts off periumbilical, and this is due to irritation of the visceral peritoneum, and then moves to the right iliac fossa over the next 12 to 24 hours. And this is then related to the parietal peritoneum. They also may present with nausea and vomiting. Most of the time, they present with anorexia, and they may also have a low-grade fever. On examination, there'll be tenderness over McBurney's point, which is 2/3 between the umbilicus and the right ASIS. There may also be other signs such as Rovsing sign, Zoas sign, or obturator sign that could be positive, and there can be signs of peritonitis as well, so guarding rigidity or rebound tenderness. An important differential for appendicitis in children is mesenteric adenitis. This often can present with very similar symptoms, but it'll often present after a viral or bacterial infection, and usually the symptoms are a bit milder. So in terms of the investigations, it can often be a clinical diagnosis, but imaging is still done to sort of confirm before surgery. You can get full bloods, and then on abdominal ultrasound, there'll be an aperistaltic or non-compressible appendix with an outer structure over 6 millimeters and then inflammatory changes as well. And I've just put an image there of an example of appendicitis on ultrasound. In terms of management, it'll be your standard surgical workup that we discussed earlier, but the definitive management is a laparoscopic appendicectomy. This should be done within 24 hours of presentation, and it should be done very urgently if it is a complex or complicated appendicitis. They usually get IV, they will get IV antibiotics as well. So can be gentamicin, amoxicillin, and metronidazole, or it can be cefuroxime and metronidazole as well. I think ETG says cefuroxime and metronidazole, as that avoids the adverse effects of gentamicin. If it's an acute, uncomplicated appendicitis, these antibiotics can be ceased immediately after surgery. If it's complicated, they are usually continued for a while after until the patient's well. Our next R1 that we'll be going through is pyloric stenosis. So pyloric stenosis is hypertrophy and hyperplasia of the muscular layers of the pyloric sphincter, which leads to gastric outlet obstruction. So it usually presents between 2 and 6 weeks of chronological age, and it's rare before day 10 and after 12 weeks of age. Risk factors include being male, so 85% of children presenting with pyloric stenosis are male. Firstborn, a family history, especially a maternal history, and prematurity. And if pyloric stenosis develops for infants who were premature, it will develop at their corrected age. The clinical presentation will be vomiting. So the vomiting is recurrent and progressively more forceful. So it may become projectile. They're usually non-bilious milky vomits that can occur shortly after feeding, and the infant will be hungry post-vomiting. So the sort of buzzword pyloric stenosis is a happy, hungry vomiter. The infant doesn't appear to be in pain or sort of distressed by the vomiting. Related to this vomiting, they may also have weight loss or inadequate weight gain. Um, the vomiting can be blood stained in I think about 10% of presentations. And yeah, and then so on examination, you want to assess for dehydration. You would also want to plot their growth on a growth chart and assess for signs of inadequate weight gain. On an abdominal exam, you can assess for visible gastric peristalsis, and this will be more obvious post a feed. You can also assess for an olive-shaped pyloric mass, which is known as the olive sign. So this will be located in the right upper quadrant and is usually best felt when the infant, like from the infant's left side, when the infant is settled and supine. Um, but the important thing to note is that the visible peristalsis and the olive sign can be hard to appreciate and might not always be there if the child has pyloric stenosis. So the absence of these signs shouldn't rule out this diagnosis. In terms of investigations, sort of the really key one for bloods, you'll do full bloods, but the key one is a VBG. Um, Pyloric stenosis has a very characteristic hypochloremic, hypokalemic metabolic alkalosis. So this is caused by a loss of hydrochloric acid through in gastric fluid through the vomiting, which then causes an alkalosis and then also the the hypochloremia. Hypokalemia is caused by potassium being lost through the vomiting, but then also through further through the renal compensation for the vomiting. Um, the other investigations you'd like to do would be an abdominal ultrasound. So this is very sensitive for diagnosis. And on abdominal ultrasound, there'll be an elongated hypertrophic pylorus, which we can see there in this example ultrasound here. Abdominal x-ray isn't necessarily needed, but if done, match a dilated stomach. In terms of management for pyloric stenosis, so you do your standard surgical workup like we discussed before. The definitive management is a pyloromyotomy, which is basically where the that sort of hypertrophy of the pyloric sphincter is sort of cut to relieve that obstruction. It has really good outcomes and is usually successful. Post-op, the infant can be fed after about 6 hours and then has a couple of days of observation in hospital and then is fine to be discharged home. But the really key thing to think about in management of pyloric stenosis is the fact that the dehydration, electrolyte disturbances, and acid-base abnormalities must be corrected before surgical management. This is because there's a risk of a decreased respiratory rate during surgery because of the compensation for the electrolyte imbalances. And then that then increases the risk of hyperventilation or apnea post-op. So it's really important to correct the dehydration with fluids, manage these electrolyte disturbances before taking them to theatre. Our final R1 that we're going to be going through today will be intussusception. So intussusception is defined as invagination or telescoping of a proximal segment of bowel into the distal bowel lumen. So this is typically the ileum moving into the cecum via the ileocecal valve. And I've got an image here of sort of what that telescoping of bowel looks like. It most commonly occurs between 2 months and 2 years of age. And risk factors include a past history of intussusception, being male, recent bowel surgery, recent viral illness, recent rotavirus vaccination, or a potential lead point. There can be complications of this sort of telescoping, such as bowel obstruction, venous congestion, bowel wall ischemia, and perforation. Most of the cases of intussusception are idiopathic, especially in younger children. It's typically due to hyperplasia of Peyer's patches and lymphoid tissue in the intestinal wall from a sort of preceding viral infection. However, in older children, it is more likely to be caused by a pathological lead point. So these can be things like Meckel's diverticulum, hemangioma, lymphoma, polyps, or a foreign body. Intussusception presents with episodes of intermittent pain or distress, and the child can appear very well between episodes. These episodes can last about 2 to 3 minutes. The child during the episodes may become pale, irritable, um, draw up their legs, and the episodes can then sort of increase in frequency as well. Lethargy may be the only presenting symptom. They can present with diarrhea as well, which is common initially. Um, the buzzword for intussusception is sort of these red currant jelly stools. However, this is actually quite a late sign and suggests bowel ischemia and infarction. Um, so again, if there's no buzzword and if there are no red currant jelly stools, don't rule out intussusception as a diagnosis. They can also present with vomiting, and then sort of as I highlighted before, if it's bilious, that is an immediate red flag and indicates bowel obstruction. 1/3 of children presenting with intussusception have this sort of like characteristic triad of intermittent abdo pain, palpable abdominal mass, and red currant jelly stools. On examination, there may be a sausage-shaped mass in the right abdomen, which crosses the midline in the epigastrium or behind the umbilicus. There may be abdominal distension, which would raise concern for bowel obstruction, and there may be tenderness or guarding, which would raise concern for perforation or peritonitis. In terms of investigations for intussusception, a sort of general set of bloods, abdominal ultrasound is sort of your gold standard for diagnosis. The gold standard for diagnosis and management is a gas enema, but an abdominal ultrasound can pick up intussusception very well. If you're looking transversely, there is a sort of target or donut sign, which is sort of highlighted here. If you're looking longitudinally on the abdominal ultrasound, it's a pseudo-kidney sign. So target or donut sign is another buzzword for intussusception. Abdominal X-ray will only really be done if there are signs of obstruction or perforation, and on abdo X-ray there'll be what's known as a crescent sign, which is shown here. A gas or contrast enema is both diagnostic and therapeutic. It is contraindicated if the child's in peritonitic, is shocked, if there's any sign of perforation, or if there's an unstable clinical condition. It does carry a small risk of bowel perforation and bacteremia, but is most of the time successful in the first attempt. It's usually attempted twice. And then laparoscopic surgical correction is only really done if this enema fails. Other than that, for the management for intussusception, it's your standard surgical workup. Analgesia is important because they will have these episodes sort of pain. And the typical analgesia that's given is intranasal fentanyl or IV morphine. And then again, sort of the IV antibiotics as well. So that finishes up our overview of the Paediatric R1s for today. Thank you for listening. Again, if you've got any questions at all, feel free to send me an email, and good luck for your exams.